name's Katherine Restrepo. I'm the Director of Healthcare Policy at the John Locke Foundation, and we are a think tank, so we do a lot of thinking, as Josh said. I also try and do some doing, too. We're nonpartisan, we're a 501c3, so we can't directly lobby or anything like that, but we do work with lobbyists to influence legislators to pass good policies that will make more of a competitive healthcare market and provide more choices and access for patients at a lower cost, preferably, too. So I've been working at the Locke Foundation for about 5 years now, and I love it. And I'm really fortunate because in a lot of think tanks, especially smaller state-based think tanks like the Locke Foundation, people are often more of a generalist when it comes to policy. So you have to focus on transportation, education, healthcare, lots of different things. And at Locke, it's been great because I've really been able to really have the autonomy to focus on specific healthcare policy issues that I really enjoy. And some I certainly love looking more into than others. Love direct primary care. I first got to know about direct primary care back in 2014. I went out to Oklahoma City. We got to tour Keith Smith's Surgery Center of Oklahoma, knew about the heritage backgrounder that Dr. Daniel McCory wrote at that time. And when I learned more about it, I just fell in love, and I love talking about it everywhere I go because people from both sides of the political aisle really like it. And there's a lot of agreement that, removing primary care from insurance makes sense, and it can be really affordable when you have price transparency. And then there's other policy issues where I get lots of pushback, especially when you have to, and that's why I want to talk about Medicaid today. We're talking about policies where there's a lot of contention, and we're talking about low-income people who currently, when it comes to Medicaid expansion under the Affordable Care Act, you have certain people, this gap population in states that have not expanded Medicaid, where they don't qualify for Medicaid and they don't earn enough to qualify for a subsidized health insurance plan in the individual market if they don't get employer-sponsored health insurance. And it's hard to come across in a 30-second soundbite or a talking point to come across as not compassionate, and you sound cold-hearted when you're just talking about data, stats. How can we harness this emotional argument and really reframe the argument, saying, okay, we have this safety net. How can we preserve the resources, our limited resources, to help those who truly need financial assistance? How can we get people back on their feet where they no longer need to depend on the federal government for medical assistance? And just to give you some examples, I've talked about Medicaid at Wake Forest Law School. I was the only one on the panel against expanding Medicaid. Everybody else, including Republican legislators, were for it. I'll be honest, that was very difficult. I was trying to talk about North Carolina's free and charitable clinics. We have a very strong free clinic system in the state, and they don't accept insurance at all. And I've gotten to tour some of them, and it's really great. And they're doing some amazing things. And because they don't accept insurance, kind of like the direct care model, they're able to be really creative with how they treat their patients, and they're really able to help people who are falling through cracks and don't have enough time to spend with their physician. That's difficult. Other television news interviews, when you're asked about it, it's hard to come back and make your case in a compassionate way without people thinking that you're heartless because you don't want to expand a program for low-income people who don't have health coverage. So today, I really just want to talk to you about Medicaid, how it's designed, what is it really helping the people that it's supposed to serve? And Medicaid, more about Medicaid expansions, the arguments for and against expansion. Because I think before you stick with this emotional reaction to certain policies, I think it's really important to just know more about the program itself and how it works and whether it's actually really helping the people it's supposed to. So if you look at the history of Medicaid, brief history here, and disregard the chart for a second, but it was passed in 1965. Many of you are aware of that, along with Medicare. It was an amendment to the Social Security Act. And it was originally designed for low-income children, oftentimes single-parent households, elderly, blind, and disabled people, and pregnant women. So in North Carolina, and it varies by state as far as who is eligible. So it's not just this blanket program for people who are low income. It's really based on categories, if you fit in certain subsets of the population. And each state varies. You can have more generous eligibility levels by state, but the state's going to have to share more of the cost of that. North Carolina, we really are closer to the federal minimum of who qualifies. So as you can see here, it's based on the federal poverty level. So 210% of the federal poverty level for children between the birth to 18, that's probably around less than $20,000 a year. So it's really not much. And it's important to look at, since Medicaid's inception, it's just grown so substantially, and in enrollment and expenditures. You can think of it again as 4 different Medicaids. So it's 4 different types of people who qualify for this program. But nationally, Medicaid is the largest health insurer in our nation. Nationally, we spend about $500 billion on Medicaid. It's 10%. I just looked it up. It's 10% of the federal budget. That's very significant for one program. In North Carolina, we're one of the largest states in the union, and we have 10 million people in the state. 2 million are on Medicaid. Half of births, half of babies that are born are on Medicaid. So of 2 million of 10 million people, that's 1 in 5 people in North Carolina who are on this program. And Medicaid, it's, when I'm at the legislature and at committee meetings, when people are talking about budgeting for this program, it's very difficult to budget for because it's an entitlement program. So if you qualify, you qualify. There's no limit or cap on the number of slots of people who can be on the program. Now there is for some people, and I'll get into that in a little bit, but for the most part, for these 4 groups, there is not. And that all depends. There's lots of churn. People who are low income, but they have a job. Maybe they have employer-sponsored health insurance, but if they change jobs, they don't have health insurance, and so they may qualify for Medicaid. So there's this constant churning, and it's difficult to project enrollment. It's difficult to project utilization of services, and that's why it's hard to budget for this program. So you never know if there's going to be a shortfall or a surplus with your budgeted Medicaid funds. And I think a big part, and a lot of policy people agree with this, and this is a quote from Avik Roy. He's a very, I'm sure many of you are familiar with his work, but he's a very influential policy and thought leader in the healthcare space. And one of the biggest problems with Medicaid, I think, of how the program cost growth has just grown substantially over time, is how it's funded. I mentioned this earlier when we were doing the brief Q&A. And that's because of the way it's designed. So in North Carolina, and I'm just saying North Carolina because I live and work in North Carolina, but for every dollar a legislator spends in North Carolina on its Medicaid program, we almost get in return $2 from the federal government. So it's this incentive for legislators to keep spending money or provide additional optional benefits and services for Medicaid patients. And because, as Avik Roy says, it's not every day that a state politician gets to spend $1 of his constituents' money and gain credit for spending nearly $2.50 in return. But that's how Medicaid works. So as a result, irresponsible officials in many states have ratcheted up their Medicaid spending, knowing that taxpayers and others will be forced to foot a good chunk of the bill. So it's this incentive to keep spending money, and it's just as much of a disincentive to reduce spending or try and downsize this program in some way, because a majority of that savings goes back to the federal government because the federal government picks up the majority of the tab. And the financial design, it's technically called the federal match rate, the federal match rate, and that really varies based on the state. It varies based on how many people are on Medicaid. It varies based on income. So, for example, Mississippi has one of the highest match rates, meaning that the government funds the most of any state's Medicaid program, while Connecticut, it's more of a 50-50 match rate. Does anybody have any questions so far? Okay, I know this is dense information, but I just think it's important for you to know. So again, because Medicaid spending on this open-ended match rate, hospitals in the state kind of work together to maximize as much federal monies as they can. And keep in mind that, like, where is the patient in all this? And we'll get to that in a little bit, but it's just so important to talk about the financial design. One example is hospital assessments, okay? So this is like a shell game that hospitals and skilled nursing facilities have used in the past, where they agreed to be taxed by the state. So the state collects that revenue, and then they disperse it back to the hospital system or the skilled nursing facility. But because that's considered a Medicaid expenditure, that triggers more federal funds to come down from Washington. So the state has more money in its hand. They can give more money to the hospitals. They can keep that money. We don't know where that money is necessarily going. I mean, states have passed laws, passed laws that, they're considered provider hospital assessment policies. So it's technically legal. Yes?
Going over to that last point, I don't think I'm entirely clear. So the hospitals will collect revenue, especially advanced nursing facilities will collect revenue from Medicaid.
Mm-hmm. Yeah. So okay, say a hospital agrees to be taxed. Okay, and this isn't the North Carolina state budget. This is in other state budgets. So a hospital agrees to be taxed. The state collects that revenue. Okay, they disperse it back to the hospitals. Yes. So it's like a shell game. So when they disperse it back to the hospitals, that's considered to be a Medicaid expenditure. So every dollar that the state spends triggers more money from the federal government. So the state...
It's like double booking almost. It's claiming more.
Yes.
Essentially.
Yes.
You're giving money to receive it, but you can still count that as a tax. And it's double booking. That's what it sounds like.
Well, sure. And so you have... The state has more money from the federal government for that Medicaid disbursement, so they can distribute more to the hospital system in the form of higher reimbursement, and sometimes the state keeps a portion for themselves. So that's just one way where Medicaid spending has ratcheted up over time. Yes?
Does the state have to give it back to the hospital in the form of reimbursement rates, or can they give it as some sort of...
Like direct intergovernmental transfer? Yeah. I'm not sure. That's a good question, but I can get back to you on that. Yes. So...
But they know they're playing this game. Oregon's one of the states that does this, and it's just and they'll push all this. We need to tax the hospitals, not knowing that hospitals are actually funding all the tax bills to get that passed, because they know they're going to get that money directly back, and then all the additional Fed money that comes with it. It's a huge scale.
Yes, and this was particularly, this was really became a problem. The federal government noticed this in the late 80s. And so they kind of cracked down on that. And then in the 1997 Balanced Budget Amendment, they limited the amount of revenue that could be taxed from hospitals to trigger more federal funding. So it's still legal, but it's just limited on how much you can tax hospitals now.
So the federal government allows them to do this?
Yes.
So why would it benefit the federal government?
It doesn't. It benefits the politicians who get to give the money away.
Right.
Yeah.
That's crazy.
Yeah. I know. It is.
Okay. So for all the money that taxpayers and people are spending on this program that, again, is meant to help people with very limited resources, need financial assistance to access medical care. How's it doing? How is this program doing? And I would argue that, when it comes back to the Affordable Care Act and its mission to reduce the number of uninsured, and a large portion of the reduction in the uninsured is by states choosing to expand Medicaid. Well, I would argue that coverage doesn't mean you're going to have great access to care. And you guys see that all the time in the media when people talk about it and debate about care versus coverage and whether, the reduction in uninsured leads to better health outcomes. So I want to back off the numbers and the statistics a little bit, and a lot of health policy people who bring this debate up, coverage versus care, bring up the story about Diamante Driver. Have any of you guys heard of that story? No? Okay. Ovik Roy talks a lot about this. Michael Cannon talks a lot about this. And this is just a story of a boy, Diamante Driver, who was 12 years old, and he had a toothache one day, and his mother tried to schedule an appointment with a dentist, but since dentists are notoriously, it's harder to access dental care than it is for primary care or specialty care. And that's because, again, because of the economic issue, Medicaid pays doctors and dentists way less than what Medicare or private coverage would pay doctors. So acceptance rates are more difficult, especially new patients. I believe in Maryland at this time, the dental acceptance rate for new Medicaid patients was like 16 to 26%. It varies based on states and how much states are willing to pay Medicaid providers. But it took Diamante's mother a long time, weeks, for him to see a dentist. And by the time he saw a dentist, he had to get oral surgery. He had 6 abscessed teeth. And he had his surgery scheduled with an oral surgeon, but he was complaining again of a headache one day, and he was taken to the emergency room. He had emergency surgery. He was doing well for a while, but then he suffered from seizures, and then he ended up dying. And he had Medicaid. So again, this goes back to, having health insurance coverage doesn't mean you're going to get accessible care. So that's just one story, and there's many others out there, and that's an extreme story, but there's many where people are really, they're falling through the cracks of this current healthcare system. And towards the end, I'm going to talk about ways where we can make it better, or how people have been trying to reform and restructure the Medicaid system where this isn't as much of an issue. Now, just as much, there's also lots of quantitative data out there for patient health outcomes. And the one that I like to talk about the most is the Oregon Health Insurance Experiment. And this is an interesting case study. So the Oregon Health Insurance Experiment was conducted by MIT economists in 2008. And this goes back to in the mid-1990s. Oregon expanded its Medicaid program to certain people, but it became a budgetary crisis because the number of actual people who were enrolling exceeded original projections. So they had to freeze enrollment. But then, after a while, they decided to open enrollment back up, and they were going to do a lottery. So there was 90,000 people on the Medicaid waiting list, but they allowed for 30,000 to join back onto the Medicaid rolls. And this was actually sort of a perfect setup to conduct some type of a randomized control experiment for people who won the lottery to be enrolled in Medicaid versus those who remain uninsured. And so, after 2 years of tracking certain health measures, reports came out. The authors concluded that there was no statistical significance, there was no significant improvement in health outcomes for patients who were on Medicaid versus those who remain in the uninsured cohort. Now, there's a lot of criticism to this study. It's not perfect by any means, but this is probably, this is the closest apples to apples comparison there really is when you're looking at population who's uninsured versus that who had Medicaid. But what I like to point out here is that, despite what the authors conclude, there's still lots of different interpretations of the results. Here you have and these are all different headlines from the mainstream media. So you have 4 reasons why the Oregon Medicaid results are even worse than they look, and then Oregon's lessons to the nation, Medicaid works. So there's different opinions on how to interpret the findings. Yes?
So that paper is really interesting because the author herself, I don't know if it was her,
yes,
or the other one, published a follow-up that was basically like, I know this makes it look like healthcare doesn't work, or Medicaid doesn't work, but it does. But if you read the actual paper, like any intelligent reader of that paper can't interpret the data as Medicaid having saved lives or improved any meaningful outcome.
Right, yeah, absolutely. Yes, you're absolutely right. And this, when this information came out, this was in 2013 when people were first starting to write about it, the 2-year results. And that was in the midst of the implementation and rollout of the Affordable Care Act with the health insurance exchanges and the real controversy of states deciding if they want to expand their Medicaid programs or not. And I also want to mention that of the 40% of people who were Medicaid lottery winners, they didn't even return the application. So this this map here, this diagram here, shows those who enrolled in Medicaid, those who actually ended up enrolling, those who were screened as ineligible, and those who didn't even bother to fill out the application. So, and I also want to point out that, even though, like you said, Amy said, well, this certainly, she still thinks that Medicaid is working, it's helping improve patient health outcomes. I would also argue that there was a lot of biases in favor of Medicaid for this study. For example, Oregon Medicaid providers are paid more compared to other states, so the acceptance rates is much better. Plus, you could argue, well, utilization rates were higher. They were higher in the Medicaid cohort, and so if these people really needed pent-up demand for healthcare, why aren't their health outcomes improving? So again, this was in the aftermath of the Affordable Care Act when it passed in 2010, and in 2013, at that point, states were deciding or not to expand their Medicaid programs. Today, about 31 states have expanded. A lot in the Southeast, as you can see, there's still resistance to it. I know in North Carolina, for example, the legislature passed a law saying that because some governors have gone ahead and done unilateral action to expand their programs, in North Carolina, the legislature passed a law preventing the governor from doing so. So if they were to expand Medicaid, it has to go through the legislative process. And just to give you more of a background on Medicaid expansion, it actually was once mandatory under the Affordable Care Act, but in 2012, the Supreme Court ruled that it was optional. Is anybody familiar with that case? Yes? Okay. Because they ruled that it satisfied like this two-pronged test. First of all, it was once mandatory because if states decided not to expand Medicaid, then the federal government under the Affordable Care Act said that it would withhold all federal funding for its traditional Medicaid program. So for the people that it was originally designed for low-income children, parents, elderly, blind, and disabled people. And that would be a severe economic blow for these states' budgets. Again, if we go back to that federal match rate, a majority of that funding comes from the federal government. So they considered that coercion. They said, no, this has to be optional for states to comply with. And that was in a 7-2 majority court ruling in 2012. So who qualifies? Who qualifies under this program, under the Affordable Care Act? And it's really a majority of people don't have children, and they are working, they're employed. That's the majority of people who would qualify under Medicaid expansion. And again, it would be a strong incentive. Many states have expanded so far because, again, if we go back to that federal match rate, the federal government promised, okay, for the first 3 years, if you decide to expand to this population, we'll pay for that population 100% for their medical benefits for the first 3 years. Then starting in 2020, the state would pick up more, start before that, but now in 2020, the state would pick up about 10% of the cost. And you think, so that's a 90-10 match rate. So that's pretty significant dollars that the federal government's picking up. So sure, this is an incentive for states to expand, but how can you be so sure that the federal government's going to continue funding that very generous match rate in the future? There's so much, you do not know what's going to happen at the federal government. It's so unpredictable. In this current administration, things are just so unpredictable. So yes, it's very attractive, but that 10% is still pretty significant. And in North Carolina, if we did expand, we haven't, but if we did, that would add up to $6 billion over the next 10 years. So that's another $600 million the state would have to pay for every year for 10 years. And that's really significant. That's a lot of money. Considering that the state shares about $3 billion to fund our own state's Medicaid program. Okay, now I want to give you some more of the pro and con arguments to expansion. It's not working. Okay. So for states that haven't expanded, you'll hear a lot in the media that there's this gap population, right? So you have people who are don't have dependents, don't have children, they don't qualify for Medicaid, nor do they earn enough to qualify for a heavily subsidized private health insurance plan in the individual market. Again, that's if you don't get health insurance through your employer. So that's really the gap population right here. And that is what makes this whole entire issue very contentious because, again, under the Affordable Care Act, it used to be mandatory, but it's not. It's no longer mandatory. It's optional. Plus, it's not fulfilling the Affordable Care Act's mission of reducing the number of uninsured, and that really would be under two major components, one being Medicaid expansion and the other with distributing subsidies in the individual marketplace. So there's some of the arguments that you'll hear and that you've probably heard about expanding Medicaid is one, that it's going to create so many more jobs. Well, is Medicaid really supposed to be a jobs program? And if it is, I mean, as far as I'm concerned, it's a health insurance program for people. But if it is a jobs program, if you're going to create more jobs out of it, well, you're pumping more subsidies into the economy. So that's taking money out of your pockets, out of your family's pockets to fund this program, fund these jobs where, okay, so there's trade-offs here. But studies consistently show, mountains of clinical evidence show that this is not significantly helping people's health outcomes. And then I think, one of a strong argument is, okay, well, if people have primary care, they have an insurance card, they're not going to walk into the emergency room. Because we know that the emergency room is the most expensive point of entry into the healthcare system. Yes, that's a great point, but even before the Affordable Care Act, other states that like Oregon and others that have expanded their Medicaid programs, there's not significant evidence that this has really drastically reduced unnecessary emergency room rates.
Doesn't it increase emergency room access?
Yes, and it has, because again, you have more people on this program and not enough providers to offer their services. And then, other arguments are, well, if we're not expanding Medicaid, we're helping other people's Medicaid. We're funding other people's Medicaid programs, so we need our piece of the pie too. And yes, we are funding other people's Medicaid programs, and we are even when we're not expanding it because it's a jointly funded program. But really what's happening is that you're just merely adding to the federal deficit, and you're taxing future generations, and you're not really solving the current issue right now. So there's lots of fiscal costs and human costs associated with it. There's lots of private coverage crowd out. So again, the more people you have on Medicaid, even Jonathan Gruber, who's an architect of the Affordable Care Act, he's done studies on private coverage crowd out and says the more people you have on Medicaid, in fact, for every 10 people on Medicaid, 6 people once had private coverage. And it becomes really this vicious cycle. So, we can talk about reforming Medicaid and restructuring the system. It's a very dense issue. It's a dense topic. And that's why I love being here and talking to you guys, because you guys are the future of medicine. You guys are the future of healthcare, and you're all leaders here. And it's great to be here to talk to you because you're all interested in innovation. You're interested in pursuing strategies to help people at a lower cost and faster. I love talking about telemedicine. So many direct primary care doctors are including telemedicine in their practices. It's preventing unnecessary specialist referrals. It's lowering people's total out-of-pocket costs. Surgery Center of Oklahoma, people who are employed, their employers, it is so, this is a completely price transparent model for surgery, and people who have jobs and get health insurance through their employer is paying for their flight, their hotel, their entire trip in addition to their surgery, because it's so much less expensive out of pocket for them compared to the hospital 5 miles down the road that you don't even know what they're going to charge. And then again, I was talking about earlier about this direct primary care practice, St. Joseph Primary Care, and they have 2 clinics now, and this is a true nonprofit direct primary care clinic where, again, you have the benefactors who there's a surcharge built into their annual or monthly membership fee, and that provides that surcharge is able to offset the cost for those doctors to provide free charitable care for people who are unable to pay. So with that, I'd be happy to take any other questions, and I just think that when we look at Medicaid again, how can we reframe the debate, not the debate, but the conversation, and as Beth was saying, have a good conversation on, how can we help people not have to depend on the government for services? And then we can limit that safety net and preserve those funds for the people who truly need it at that time. So thank you.
I know it's the end of the day. It's an important topic, though. Anybody got questions? Okay. Oh, yeah.
What's the big thing you disagree with Ovik Roy on?
He believes in the idea of universal coverage, but doing it in the most market-oriented way. And I still think that, people should have the option if they want to purchase health insurance for themselves or not. Yes. He wouldn't do it through an individual mandate or anything like that, but that's what he preaches, I think. Yeah.
He also has a argument that there is data that shows people who are uninsured have better health outcomes in some cases than people who are on Medicaid. Trying to make the argument that you're better off uninsured than having Medicaid. And there's a guy, I'm blanking on his name now, Austin Fracht, the incidental economist, who I think has done a fabulous job of disproving that. So we really have to be careful, even though something sounds good and seems to be feeding, be a point in our favor, you still have to go back and look at that data. So when I looked at the studies that have been referenced, and yes, those particular studies do show that there's some flaws to that, I think the overall evidence shows that when you really compare equally sick, equally poor, equally lack of social support people on Medicaid to those who are uninsured, you're better off on Medicaid. And the reason that the uninsured seem to be doing better is because they tend to be better off, have better social supports, and aren't quite as sick. So just be careful. Even the statistic that you like and you want to use, you better do your homework or have somebody that has to make sure that you're really arguing. Or if you use it and somebody criticizes it, listen to them and listen to the criticism and go look at it.
Yeah.
This country that doesn't have Medicare at all?
No. These programs are just so rooted in and are just so expansive. That's definitely, if you look at payer mixes at hospital systems, it's 65% is Medicare and Medicaid combined in general. So I think that's just they're both such huge payers, I don't think that's going to go away anytime soon. They're not sustainable. I don't know what you want to say about that, but.
They're not sustainable as currently instructed as a limitless entitlement. Mm-hmm. So the way that they will become more sustainable is we'll be seeing something more like the NICE, where they're limiting what those governments programs
will pay for. Yes. Okay. All right.
All right.
Thanks.
Thank you.